Every year, 3.2 million seniors are denied medical care through Medicare Advantage, yet more than 80% who fight back actually win. So why do almost none ever appeal? The answer reveals a system profiting from silence, where the cost of giving up is measured in lives, not just dollars. The real story behind these numbers begins now. Medicare Advantage plans process an enormous volume of medical requests every year. 46 million prior authorization requests alone, nearly 2 for every enrollee. Out of these, 7.4% are denied at the outset. That means millions of requests for doctor visits, treatments, or prescriptions are stopped before care can even begin. But the denials don't end there. When all types of claims are counted, including payment requests after care is delivered, the rejection rate climbs to 17%. For providers, these denials aren't just paperwork. They translate directly into lost income. National surveys and claims analyses show that on average, hospitals and clinics serving Medicare Advantage patients lose about 7% of their expected revenue each year because of denied claims that are never paid. In high-cost categories, like skilled nursing, home health, and specialty drugs, denial rates and financial losses run even higher. These numbers are not abstract statistics. Every percentage point represents real patients, real treatments, and real dollars lost to a system that routinely withholds care. The data reveals a system where denials are not accidental outliers, but a predictable part of the business model. For every claim that is denied and never challenged, the financial benefit flows straight to the insurer, while both patients and providers bear the cost. Filing an appeal sounds simple on paper. In reality, fewer than 1 in 10 seniors ever challenge a denial. The reasons start with the first letter. Denial notices arrive dense with legal jargon, often written above a 12th grade reading level. For many, the letter is hard to understand, buried in cross-references to plan documents and federal codes. Even those who spot the right to appeal face the next obstacle: time. The deadline to act is short, and the instructions are rarely clear. A missed step or a late form can end the process before it starts. Reaching out for help brings its own hurdles. Plan hotlines and Medicare assistance numbers routinely leave callers on hold for 20 to 45 minutes. Seniors with limited mobility, hearing loss, or health complications may be unable to wait. Those who do get through often find themselves transferred between departments, repeating the same story each time. Digital options are no easier. Online portals demand passwords, document uploads, and computer skills not everyone has. Caregivers try to step in but run into barriers of their own. Many clinics are understaffed, with little time to help patients navigate appeals. Even when families want to fight, they struggle to collect the right paperwork or reach someone who can explain the rules. The result is a system where confusion, frustration, and fatigue silence millions. Instead of a fair shot at care, most are left with a rejection and nowhere to turn. The burden falls hardest on those already vulnerable, turning a bureaucratic process into a wall too high to climb. Evelyn's world narrowed the day her insurance letter arrived. She had been counting on home health therapy after her stroke, but the notice said the service was not medically necessary. No one called to explain. She stared at the dense paragraphs, unsure where to start. Each day without therapy, her left hand grew stiffer. Simple tasks, buttoning a shirt, pouring tea, slipped out of reach. Her daughter, Carla, tried to help. She balanced Evelyn's needs with her own job, making phone calls in between meetings, waiting on hold, only to hear, "We can't discuss this without a provider's statement." The clinic's front desk was always busy. When Carla finally got through, the nurse apologized. Too many patients, too little time. Weeks passed. Evelyn's doctor faxed another letter, but the appeal instructions weren't clear. Carla worried she had missed a deadline, At night, Evelyn lay awake, afraid she would never regain her strength. She stopped asking about therapy, not wanting to be a burden. Bills for transportation and new medications arrived. The family cut back on groceries to pay for a few private sessions. Each session made a difference, but they couldn't afford many. Carla called the plan again, this time with the doctor on the line. She was told to resubmit everything. The process felt endless, hope slipping away with each unanswered question. Only after a local advocacy group stepped in did Evelyn learn she could still fight the denial. Until then, the system had offered only silence and setbacks, leaving her to wonder if anyone was truly on her side. Every Medicare Advantage denial comes with a right to appeal. But the process is tightly regulated by deadlines and paperwork. The first step is the written appeal, known as a reconsideration. Seniors, caregivers, or their doctors must submit this request within 65 days of receiving the denial notice. Missing this window almost always ends the chance for review, for urgent cases like a treatment delay that could cause harm. There's an expedited track. Marking the appeal as fast triggers a 72-hour response requirement from the insurer, but the paperwork must still be complete. A successful appeal starts with the right documents. The checklist is exact: a written appeal letter or the plan's form, a copy of the denial notice, the enrollee's full name, Medicare number, plan ID, contact information, and a clear statement of what's being challenged. A doctor's letter explaining why the care is medically necessary is critical. Medical records, like test results, visit notes, or discharge summaries, should be included to back up the case. If someone other than the patient is filing, a signed CEMS 1696 appointment of representative form is required. Submitting proof of when the appeal was mailed or faxed can protect against missed deadlines. Plans must accept appeals by mail, fax, or sometimes through an online portal. Incomplete paperwork, missing the denial letter, or leaving out the provider's statement can lead to immediate rejection or long delays. Each step is a hurdle, but every completed appeal is a chance to overturn the denial. The rules are strict, but the pathway is real. Armed with the right documents, most appeals succeed. Inside the walls of major insurers, denial isn't just a byproduct. It's a business process. Claims processors work under strict productivity quotas, measured by how many cases they close each day, not by the accuracy or fairness of those decisions. Internal memos circulate with phrases like "deny first, review later," instructing staff to reject questionable claims up front, knowing most patients will never push back. Proprietary algorithms and automated templates speed the process, flagging requests for quick rejection if they don't check every box. Some plans use scripts that require staff to cite specific regulatory language in every denial, even when the clinical record might support approval. The faster a case is closed as resolved, meaning denied and left unchallenged, the better it looks on internal dashboards. These metrics feed directly into performance reviews and ultimately profit margins. For every claim denied and not appealed, the insurer keeps funds that would have paid for patient care. The system is designed to move quickly, close cases, and minimize payouts, leaving patients and providers to navigate the fallout. Watchdog groups have sounded the alarm about persistent blind spots in Medicare Advantage oversight. Despite repeated warnings, federal regulators do not require plans to report all types of denials. Payment denials, where care was already provided, but reimbursement is refused, often fall outside mandatory reporting, leaving a major gap in public data. Some plans also fail to distinguish between full and partial denials, or between prior authorization rejections and payment refusals, making it nearly impossible to track how many seniors go without care or lose coverage after treatment. Investigators have pressed for clearer, more complete data. But progress stalls under political pressure and industry lobbying. Lawmakers cite modernization delays and competing priorities, while advocacy groups argue that missing categories and inconsistent reporting mark the true scale of harm. Without full transparency, millions of denied claims remain invisible, and reforms are slow to arrive. The system's blind spots protect insurers, not patients, and keep the public from seeing the real cost of inaction. Each year, over 3.2 million seniors are denied care by Medicare Advantage plans. Yet more than 80% of those who appeal see those denials overturned. Despite this, less than 10% ever file an appeal. Blocked by complex paperwork, long call waits, and unclear instructions. Internal documents show some insurers use deny first, review later policies, and government watchdogs have found missing data on payment denials and slow regulatory response. The full extent of private insurer algorithms and financial incentives remains hidden, leaving unanswered questions about how many medically necessary treatments are never delivered or reported. What is clear? Profit-driven systems and oversight gaps allow these denials to persist. Regulators, advocacy groups, and patients now push for transparency and reform. The evidence shows that when seniors appeal, most win. The challenge is ensuring every denial is questioned and every patient knows their rights. Justice is possible, but only if the fight is brought forward.